these classes. I believe some of you guys have labs still, but we won't be having the regular classes. Okay.
Dr. Donahue, I have a question.
Yeah, go ahead.
The exam is going to be on Monday. On the schedule, it says it's for Wednesday, 11/18. Just double checking.
Then it's going to be for Wednesday. I forgot because we have the venipuncture scheduled. The venipuncture practicums, everything's a little thrown off. Then yes, it'll be on Wednesday. Thank you for that correction. So Wednesday, guys, that means on Monday for this class, we'll do a review for the class. I'll put together a review for you guys. I usually do. Make sure you're ready to go for it. So Wednesday will be the exam. Y'all watch me. I don't even know what day it is anymore. I've got so much going on. I'm moving to my new house tomorrow. Closed on the paperwork yesterday. Everything's completely topsy-turvy right now. Plus trying to get this International Day stuff done. So y'all make sure I'm making sense here. I don't have my head quite screwed on straight today. Thank you. It has been a long process. But just a quick little story. They say that God works in mysterious ways and you never know why things are delayed until later. Well, check this out. So yesterday, we had a housekeeper going over to our new house to clean the floors, make sure it's all nice and clean before we move in. And the electricity was off. So he crawled up into the attic to go see if he could flip the breaker box on and get some electricity so he could start cleaning the floors. Well, he was walking past the hot water heater, and he noticed as he walked past the hot water heater that it was on the verge of exploding. Yeah, it was about to explode. So he runs out of the house really quick, calls our realtor, lets her know, and she real quick called the original owners, and they agreed to replace the hot water heater for us before we move in. It saved me $1,100, and had this not all been delayed, I'd probably be in that house right now, and that thing would be exploding, causing all kinds of damage, water damage, horrible stuff. But everything happens for a reason. It got delayed for a reason, and we avoided that horrible situation, thank goodness. So you never know. You never know why you go through hard times. You never know why things go crazy. Sometimes you find out a little later, and it all starts to make sense. Is that not the most 2020 thing ever? Just 2020, man. It's going to be a meme next year. We talk about 2020 as this weird year where everything that can go wrong, but hopefully, there's always a light at the end of the tunnel. And good things come around for a full circle. So hang in there, guys. Hang in there. I'm still being very hopeful that we're going to be back in person soon. I've already talked to some of you guys for the practicums. We're wanting to be back in person desperately. It was good to see you guys in person for your practicums. The other half of you I'll see on Thursday and next Tuesday. Soon. We'll get this all back to normal. I'm being positive. All right, let's get back on subject here, everybody. So we had talked about the different types of administration when it came to doing venipunctures. If you remember, we got the intramuscular, subcutaneous, intravenous, and intradermal. All have their own different angulations in which we have to actually insert that needle. Of course, the most important out of those four, once again, is the intravenous method, which would be 25 degrees on average, but there is a range on that. It can be from 15 to 25 degrees. 25 being the most common, but you do have a little bit of range, depending on how those veins react when you're actually performing that venipuncture and injecting into the vein. And those of you that have already done this with me at the practicums, we got some stubborn veins to work with on that arm that we're using. But that's not because That's just because that arm is pretty worn out. It's been through some difficult times. You'll see what I'm talking about when we do it in person, for those of you who have not experienced that yet. But man, the class yesterday, I got to say, I like a little competition, guys. The class yesterday, they rocked out those venipunctures. They almost all got it on the first try. I got to say, that's pretty impressive. I am sorry to say to you guys that were in the first class, but they kind of rocked that out yesterday. But it was luck of the draw. The arm decided to cooperate a little more yesterday overall. He was in a better mood yesterday. Okay, so some supplies here, guys. So this is where we left off. I'm sorry, this is the slide we left off on. You remember angiocath is going to be the most common type of device that we use in the medical imaging field. That's the safest device and the most effective. And one thing I didn't say last time, one reason that we really like to use as angiocaths is they really handle contrast medium flow a lot better than, say, a butterfly or other types of devices. Contrast medium goes into our patients through their veins at different rates, especially when you talk about MRI and CT. They use what's called power injectors. If you haven't seen that yet, there's actually these things called power injectors that we hook those angiocaths to via tubing, and it automatically injects using a pressurized system. So obviously, if we're doing a high pressure automatic system, we need a device that's going to handle it well. So you wouldn't opt for a lot of those lesser needles because you might blow the whole thing up. You might cause what's called an extravasation, which we'll go into that in a second. A very painful thing that can happen where the vein explodes and contrast begins flowing into the cavities of the body in places we don't want it to be. But if you do remember, those needle gauges, the higher the number, the smaller the diameter, the lower the number, the larger the diameter. It's about how big around that needle is. You got the ones that are bullet sized over here, the ones you don't want to be injected with. I think that's what they use with penicillin needles. I swear penicillin needles, they want to be as painful as possible. If you ever had a penicillin shot, you know what I'm talking about. Versus the high number, like the butterfly needles, they're very thin, and you can barely feel those when they inject them unless you tense up your arm. I swear, I don't know what it is about the past 2 flu shots I've gotten. I swear the nurses have had it out for me, and they've purposely tried to hurt me. A little story on that. I got embarrassed with one of my students. It wasn't this time around, but last year I went to get a flu shot with some of the seniors, the now seniors, and Ms. Amna Minhas decided to tell the nurse to make sure she hurt me during my shot. I deserve to be hurt. Well, I don't know if the nurse listened to her, but I swear I went in for my shot after that, and I swear she got me right on a nerve in my arm, and it hurt like heck. Yeah, you remember that, Tracy? I think you were there too. Yeah, it really hurt. It really hurt. So I've never let her live that down. I said, I'm never getting a shot with you again. Nope, you're going to sabotage me. But I think the nurse got the memo this year because she hurt my arm pretty bad as well. I didn't even tense my arm up. It's like they got me right on the nerve. It hurt like heck. I hate flu shots. They make me sick every year. I swear, the flu every year anyway. I hate getting flu shots, but it's required. All right, so talking more about parenteral administration. So we have 3 main portions of the actual needle we need to know about. Not every needle looks exactly like this, but most commonly, they're going to be made up of the bevel. The bevel is the tip. Cannula or shaft, the middle, kind of like the bones we've learned. And the hub. The hub is what hooks to the syringe or the injector that's injecting the contrasts. Now, the bevel is further broken down to 3 parts. The very point of the bevel is the point, called the point. The middle is also called the bevel. And then the most proximal portion would be the heel bevel points. So 3 main areas of the needle, 3 main areas of the actual bevel or tip. And then all forms of parenteral administration, of course, must have a needle, syringe, and container. One thing that's really important about the container is whenever you insert a needle parenterally, you always look for what's called flashback. If you don't get flashback, which is blood flowing into the tubing, that means you're not in the vein. So you gotta have a container that's going to collect that blood, make sure you got that needle in a nice good spot before you tape it down, because we never want to administer any kinds of contrast or medication until we know for sure that needle's in a vein. Otherwise, once again, we're going to cause a condition called extravasation, which I'll show you what that looks like here in a minute. I've actually experienced that with an injection that I did in CT. Quite scary when it happens. And one advantage to parenteral administration, one reason we love to administer directly in veins, is it's going to work a lot more rapidly versus someone just ingesting a contrast medium or a medicine. If we're going directly to that bloodstream, that is going to work almost instantaneously. And especially when it comes to contrast, when you do CT and MRI, you're going to light up those organs automatically instead of having to wait for what we call delayed films, much like we would for upper GIs, barium enemas, and so on, because you got to wait for that barium to get to the spot you actually want to visualize. With parenteral, it's almost instantaneous within seconds. That's why it's a big advantage to administering directly into those veins. One thing that's really important, if you ever get the experience doing this in clinic, I'm hoping the techs will share this with you. You always want to make sure there's no air in those syringes. One of the most horrible things you can do is to inject anything, whether it's medication or contrast or whatever, into a patient with air in that tubing, air in that syringe. If you inject air in there, it actually can be very dangerous, very dangerous. There's actually methods to eliminate the air. That's something that we'll learn as we move forward as well. But you always want to push that air out. Make sure you only got purely liquid in that syringe. You're not actually injecting air into the veins. Okay, a few supplies here. We have what's called a standard hypodermic syringe, an insulin syringe, tuberculin syringe, and pre-filled syringe. All four are used for different reasons, but this is the four most typical types of syringes available to us in medical imaging. Insulin syringe obviously is used for actual insulin injections, tuberculin for tuberculosis patients. Pre-filled syringes would most of the time apply to saline flushes. Now, when you get more into CT and MRI, anytime you're about to make any kind of injection with those power injectors, you always got to check the line with a saline flush. You inject the saline with that pre-filled syringe to make sure the line is clear and to double check and make sure it's actually in that vein, because once again, the last thing we want to do is ever administer contrast or anything for that matter without that needle directly inside that vein and secured, or it'll cause once again what's called extravasation. So when you see pre-filled syringe, that's most time referring to a saline flush. There's other types, but the kind you'll most commonly see in medical imaging would be a saline flush. Excuse me. And of course, standard hypodermic syringe would be your traditional one that we went over. It doesn't have anything in it until you actually withdraw blood, contrast, whatever, and fill it up. Okay, so a lot of our IV administrations use what's called a Heplock. Heplock is a very helpful device that will be hooked onto a lot of these administration needles that we're using. This actually, I'm sorry, not needles, but actually will be hooked onto a patient so we can actually administer drugs without having to do an additional needle stick. They've gained a lot of popularity over the years. They're very widely used. It's a completely needleless system, and it allows us to inject that contrast anytime we need to. It allows us to inject medication anytime we need to without having to constantly stick the patient. So it'll be a pre-fixed area that's been stuck. Like they'll have a catheter already in their system, like maybe in their chest, in their arm. It'll be secured with that Heplock, and then we simply just need to hook our syringe to the end of it, screw it on real tight. We can inject contrast. We can inject drugs without having to constantly stick our patients. So once again, that will be a pre-stuck syringe. A pre-stuck IV. You put the Heplock on the end of that IV, then you can always inject as needed. So if a person has a long hospital stay, they'd be using these Heplocks. That way we're not going in every day and constantly sticking them in the arm over and over and over again. We can use the same site using that Heplock. Like I said, just the end of that syringe will screw right on. You don't have to actually use a needle. Screw it on there. You can inject your medication, contrast, whatever it is you need to use. And these are very helpful when it comes to CT and MRI. I'm talking a lot about CT and MRI, and the reason for that is you'll see when you get to your rotations, CT CT and MRI revolve around venipunctures because we administer a lot of contrast for those modalities. So Heplocks are always nice to see. So you don't have to worry about doing venipuncture. You can throw them on that table, get the contrast flowing, get that exam done very quick. Okay, so we do have two types of bevels on the types of needles that we use. You have what's called the long bevel versus the short bevel. We opt in medical imaging to use the short bevels because we mostly do intravenous injections, and the short bevels are recommended for intravenous injection. The main reason for that, when you're injecting into a vein, you're basically threading that vein. If you have the long bevel, you're going to risk going all the way through the vein versus getting it in there that first stick. Short bevels are a lot easier to get that venipuncture successfully placed versus that long bevel. Now, long bevels do have their uses. If you're doing an intramuscular exam or subcutaneous, they do recommend the long bevels. So you're not having to risk going through a vein since you're either going directly into the muscle or in between the muscle and the skin. The long bevel would be of great use. But once again, short bevels are recommended for medical imaging. Why? Because most of the time we do that intravenous injection. Upwards to like 90% of the time, that's what we're going to be doing. Of course, we have what's called aseptic technique. We know all about aseptic technique. You must use aseptic technique when you're making any kind of venipuncture injection. And we have 4 main routes of injection, which we're going to go over here a little bit later as well. And that's just showing you what that subcutaneous injection intramuscular will actually look like. If you remember subcutaneous, you're going to inject into what's called the subcutaneous layer. That is directly in the middle between the skin and the muscle. Versus intramuscular, you're going to go straight down at that 90-degree angle, directly into the muscle. Probably the most painful kind of injection right there. Not very comfortable at all. As you can imagine, anything going directly in the muscle is going to hurt quite a bit. But not too involved in that when it comes to medical imaging. That'd more so be on the physician side if they're actively doing an exam with you in fluoroscopy or in CT, like biopsies. They may have to use one of those other methods. You as a technologist would be involved with the intravenous injections. So for IV administration, we have 3 main methods that we use. We have the slow injection rate with single administration routes. That would be a hand injection. I hook my syringe up to a Heplock, or I get my IV in there and I hand inject. That's considered a slow injection. We have what's called a bolus injection. That's an administration of a drug by intravenous bolus or intravenous push. That's talking about things like the power injectors that we have in CT and MRI. It's going to be automatic using a machine with that bolus injection. Bolus is a specified amount at a specified time. And then, of course, the drip infusion, very old school way, but still used every once in a while. A drip infusion would be a very large volume of fluid, and we hook it up to the bag, like you see right here, and it drips at a certain set rate into the patient's arm, body, wherever it's actually inserted into. That would be what you mostly see people when they're hooked up to IVs in the hospital. They still use that drip infusion, although a lot of them are evolving to the bolus method. Bolus is pretty much overtaking everything right now. Especially in CT and MRI, it's 100% bolus injection. Hand injections would most of the time be done in a fluoro exam. For example, if we were injecting contrast for a cystogram with our hands, slow rate, controlled, we're doing that manually. Now, when we're talking about the venipuncture here, of course, venipuncture, it's within the name. What is it? It's a drug placed directly into a vein. Vein, venipuncture, it's all in the wording there. That needle length engaged will depend on the viscosity of the drug. Does anybody know what viscosity means? Viscosity is the thickness of the drug that we're administering. Different contrast mediums, different drugs have different viscosities. In medical imaging, A lot of the contrast we use is very thick viscosity. And one thing you'll notice when you go into MRI and CT, they keep the contrast in a warming machine. And the reason they warm it up, as we warm contrast up, the viscosity goes down. It's also why it's so important when we're talking about CT and MRI and we inject contrast, we use the bolus injections. Bolus injections are fast, and we got to keep that viscosity down as much as possible. As soon as I remove that contrast from the warmer, the viscosity is starting to trickle up because it's starting to get to room temperature. Therefore, I'm going to use that bolus injection and get that injected as fast as possible into the patient so it has a good steady flow rate and it's not going to slow down from high viscosity. Also depends on the site selected and the specific method of injection, whether we're doing a hand injection, drip infusion, or bolus. And then we're always going to make sure that we get what's called flashback when we insert with a venipuncture. It's why when we're doing it in the practicums, I look for that flashback. You must get flashback, which is blood coming into the tubing, to confirm that you have that needle placed directly into a vein. If you do not observe that and you continue with an exam, you risk causing extravasation, also known as infiltration. That means that the contrast, the drug, whatever, is flowing into the cavities around the vein, not actually in the vein. I'll show you what that looks like on a picture on the next slide. Now, if it does occur, and it does happen, sometimes nurses put bad IVs in. I've had that happen to me a lot. They'll put an IV in, you think it's secure, you check with the saline, it seems like it's okay, but the vein explodes, it bursts during the exam, and then you have an extravasation occurring. What would you do? First thing you're going to do is remove that needle immediately. You're going to apply pressure to the injection site, just like you would with any needle that you're removing from the arm. And you're going to apply warm, moist heat to relieve the discomfort because that patient is going to be in extreme pain. Their arm is going to swell up like a balloon, literally. I'll show you on the next slide what that looks like. Now, the two most popular sites that we will use for venipuncture, this is an important point, will be the brachial and antecubital veins. Brachial and antecubital veins. It's the two most popular sites, not necessarily the only sites. But whenever you get injections in your elbow, more often than not, you're going to have an injection in that antecubital space or the brachial. Antecubital space is the lateral side. Brachial is the medial. Brachial on the medial aspect of the elbow, antecubital on the lateral aspect of the elbow. And that's what an extravasation typically looks like. It literally causes the arm to swell up like a balloon because the contrast is not going to the vein. It's going to the cavities around the vein, in the tissue, in the muscles, in the skin, everywhere it should not be. When I was doing my CT clinicals, we had a vein that exploded, and this is using the power injectors to CT, and we didn't see it. All of a sudden, the patient was screaming. He was in pain. We turned the machine off real quick and ran out there, and his arm had swollen up literally like a balloon. Like if you think of where your bicep is, his arm, like it was, you can see my camera, his arm was swollen up to here. It would look like a big ball under his arm because you're using a high amount of contrast in CTs. Now, it doesn't kill anybody. It's not something that's going to kill somebody, but as you can imagine, it causes severe pain. So this guy was in extreme pain, so we had to put warm compresses all over his arm, allow that swelling to go down, and it takes a long time. But that does happen. That's why it's so important when we make these injections that we look for that flashback and we confirm that placement before we inject contrast by using a saline flush to make sure that's in a vein, because I don't have to even explain, extraordinarily painful, extraordinarily traumatizing, especially if you think if you're the patient, your arm swells up like a balloon, you'd be freaking out as well. But that's what we call an extravasation or infiltration. It's when that contrast flows outside the vein, not directly into the vein, causing a lot of pain and discomfort. A lot of people's veins actually just explode. A lot of older patients, the veins will literally explode because they can't handle the pressure. So when it comes to venipuncture procedures, guys, all common sense here, but very important points. Make sure you're always following what we call the universal precautions. Before attempting any parenteral drug administration, always check your two patient identifiers. We talked about that at the beginning of the chapter. As with any procedure exam you ever do, double check the name, double check the date of birth, have them call it back out to you, make sure you have the right patient because you do not want to be doing any venipuncture or procedure, period, on the wrong patient, and it does happen more often than you imagine. Explain that procedure to the patient, check for possible allergies. One key thing to always ask a patient when you're doing any kind of IV contrast administration, have you had any reactions to contrast before? Have you ever had any flushing? Have you ever had hives? So on and so forth. Most will tell you, yeah, I felt warm all over and I had a metal taste in my mouth. Totally normal. Not exactly an allergy. If they tell you something like I've had hives before, you'd want to let the radiologist know because most often what they'll do is they'll order Benadryl to help control that and make sure they don't break out during the exam. Assemble all your needed supplies. That goes without saying. With anything we do, make sure your supplies are set and ready to go. You don't want to look like a chicken running around with their head cut off trying to find your supplies and embarrassing yourself in front of the patient and delaying the procedure. And wear disposable gloves. So you don't need to use sterile gloves. The regular latex gloves are considered acceptable for venipuncture procedures. So when we're actually doing the venipuncture, and you guys that have not done so already will demonstrate this to me in your practicum lab. You're going to identify your preferred puncture site, which would be brachial versus antituberal. You're always going to wipe that site with an alcohol swab to begin with to clean the site. Now, an important point with the alcohol swabs, you must always wait for the alcohol to dry before you stick the arm. It's very important. That can actually cause the patient a lot of pain if the alcohol gets into the site you're injecting. So you'll see a lot of people wave the site, wave their hand over it. It does dry quite fast. Make sure it is dry before you start the injection. Also, we're always going to apply a tourniquet. The tourniquet goes above the elbow in the humeral area. Don't ever put the tourniquet on the forearm. I've seen people do that. Bad idea. Tourniquet goes really on your bicep muscle above the elbow. Why do we do the tourniquet? The tourniquet will restrict some of the blood flow and allow those veins to pop out a little better so we can see them. We can inject them a lot easier. Also, what we'll tell our patient is what we'll tell our patient when we apply the tourniquet is to make a fist and squeeze their hands. It's going to cause those veins to pop out a little easier as well. A lot of places will have a little ball they can squeeze. The place I go, my doctor always gives me a little ball to squeeze to help the veins pop out a little easier. So while you're stabilizing that vein, you found it, you're ready to inject. When you hold your needle, you're going to insert the needle with the bevel facing downward. The bevel has a slant to it. Draw that for you. There's your needle. Comes to a point like so. You want the slant going downward. Whoops. Well, my drawing's terrible there. You want the slant going downward when you insert. You don't want the bevel side up. You want the bevel side down for proper injection, proper insertion of the needle. And that needle will be inserted at a 15 to 25, I should say 25 degree angle. 25 being the most common, but 15 to 20 degrees gives you a little range. Should that vein be acting squirrely on you and you can't get it, you have a little bit of range. You can actually insert that needle at different angles. And gently advance it into the vein. Don't be like some of those crazy nurses where they just like stick it in your arm like a bullet, causing pain and going straight through the vein. And please, for the love of God, guys, do not ever dig in the veins. If you've ever had a nurse dig in your veins, it is not comfortable. I've had a nurse dig in my veins. That means they miss the vein and they dig around inside the arm with a needle trying to find a site where that needle will go in the vein. I don't think I need to explain. That's very uncomfortable and very painful. If you miss the vein and you don't get flashback, pull the needle out and start over. Don't dig for veins. Bad idea. And like I said before, guys, to verify that needle is actually in the vein, we look for the blood backflow, and that's what we call flashback. That means the blood's going to go through the tubing of that needle. When we see blood, we should stop advancing the needle. That's a key point. When you're making a venipuncture injection, when you see that blood flashbacking, stop inserting the needle. You're in the vein. That's as far as you need to advance. If you keep going forward with the needle, you're going to go straight through the vein and have to start over. Once you get your flashback at that point, you can remove your tourniquet And you can actually secure the needle with a piece of tape and begin the actual contrast or medication injection. When the injection procedure has completed, remove the needle, and of course, we must apply gentle pressure to the site with gauze. Have the patient hold it. Go get them a Band-Aid or piece of tape. Put that on the site. And always tell your patients, especially your older patients, you need to leave that pressure on the site for at least 30 minutes. A lot of our older patients do not clot blood as easily as us more younger people. Make sure they leave it on at a minimum of 30 minutes to have proper clotting of the site. Then, of course, dispose of the syringe and needle properly. And where is the proper place to dispose of a syringe and needle? Someone please tell me. That's very important.
Sharps container.
The Sharps container. Make sure it's in the Sharps container, not the biohazard box or biohazard bag, like many of you told me this week and last week. Make sure it goes in the Sharps container. It's very important. Why is that important? Because staff that comes to clean the rooms, they remove those bags. If you put needles in the trash can or the bag, that staff can grab the side of the bag. If the needle was not retracted properly, they just stab their hand with an infected needle. That does happen. Make sure those needles go in the Sharps container. They can get you in a lot of trouble. And of course, once you've disposed of that properly, make sure you chart the relevant information. That's referring to documenting everything you did, document the site, time of injection, how much contrast you use, and if there were any reactions that the patient had during the procedure, even if it's something as simple as feeling flush, hot flashes, or metal taste in the mouth. For drip infusions, that's once again when we're using very large volumes of fluid. Most of the time, that's a saline injection going to the patient via IV. It's a slow rate of injection, keeping that patient hydrated. Most of our inpatients will have drip infusions, but every once in a while, we'll use a drip infusion for certain procedures. For example, a lot of doctors will use a drip infusion for a cystogram because they want the contrast to enter the bladder at a certain slow rate. A lot of our barium enemas, sometimes we'll use drip infusions as well. It depends on the exam and what the doctor actually prefers. One thing to remember when it comes to these drip infusions, a lot of them have actual machines hooked up to them. Actually, most of them do these days. Make sure you're paying attention to the IV pump alarms. I'm sure some of you by now have walked in the patient rooms where those things are beeping like crazy. I swear they never stop beeping. You'll hear it in your sleep. Once you do this for many years, you hear those beeps in your sleep. Don't ignore them. You'll learn how to silence them. Learn how to see if there's an issue going on, if there's an occlusion going on. What an occlusion is a blocked drip infusion. The lines actually become twisted or blocked. Let the nurses know. Let the physicians know. That way that patient can get their drip infusion going properly again. Don't just walk away, say, it's not my problem, just here to do a chest x-ray, whatever, goodbye. Know what the alarms mean. Know how to silence them if you need to. And, of course, communicate to the right people to make sure they fix that quickly and efficiently for the patients. And that's what those little IV pumps look like on those drip infusions. They're actually a little more updated. That's a very old picture. Once again, make sure you know what those alarms are, what they mean. Most of the time on these little readouts, it'll tell you. It'll say line occlusion or drip infusion has completed. You want to let somebody know when that happens. Please let somebody know. Now, why do we have these? Well, the automatic little pump assemblies, they regulate the flow rates. You can do a fast versus slow drip infusion. Counts the actual drops going into the patient, and it compresses the IV tubing to adjust the flow. This is most of the time what's mostly used these days for most of our ER patients and inpatients when it comes to drip infusions. And most of these little devices will have an alarm silence button. The picture's not very clear, but usually it'll say silence. On that note, don't just silence the alarm because it's annoying you. Make sure you see why it's beeping first before you silence it, and then let somebody know. Because it does get very annoying. I'm sure you guys know what I'm talking about. Those things, they beep. For me, it's like fingernails on a chalkboard. I can't stand it. I always see why it's beeping. I'll let somebody know, and I'll silence the alarm so it doesn't drive me crazy. I hate that noise. Can't stand it. I swear it never fails that every nurse that sends an inpatient down with an IV drip, they always have those alarms going off and no one ever touches them or fixes them, and it drives you nuts. It always drove me nuts. I always call them right back over to fix it. Come fix this, please. Lines occluded. Please help your patients. Your alarms are driving me crazy. So in conclusion, guys, we didn't go over a lot of pharmacology. We went over the main points. When it comes to more pharmacological concepts, the next chapter that we're going to get to, guys, we're going to actually start naming specific contrast mediums that we use in radiology. It's going to get a little more complex, but not too crazy. We're going to keep it simple and to the point you need to know. But of course, we must have a basic knowledge of pharmacology, and we must know how to properly administer drugs under the supervision of a licensed practitioner, and make sure that we're familiar with the actions, precautions, the allergies, the effects, what can happen, know the names, know the abbreviations, know your sites, know the signs to look for, a lot of things that we must constantly have in our minds when we ever administer anything orally, parenterally, or any other methods that we use in radiology. And one more time here, guys, because this is very important. I put this on the last slide because one of those big gold star questions that you're sure to get on your contrast, on your registry. I told you guys I'm losing it today. On your registry is those 5 rights for the patient: the right drug, the right amount, the right patient, the right time, and the right route. Do not forget those 5 golden rules when it comes to drug administration. And as always, guys, make sure you do what? Document everything that you do. Whether it's drug administration, whether it's a simple x-ray, document it, cover your tracks, keep yourself away from any liability issues. You'll have a long, prosperous career as long as you always take care of those concepts. And be very careful, very careful. So while you guys are finishing up that last slide, does anybody here have any advice to those who have not done their venipunctures yet? Any pro tips? Because you guys were rocking it out so far. Any kind of pro tips for the others? Because some of them got to go tomorrow, some have to go on Tuesday. Anybody? Anybody got a suggestion? Nope, you're just going to let them go in blind? Cold turkey? Good luck? Where is the camaraderie? Where's the teamwork? Thought we were a team here. How disappointing. Y'all just tired today? It's okay, I am too. I am too. Well, any questions on what we discussed today, guys? Any questions on this chapter? All right, well, that will do it for this class today, guys. I'm about to go into finalizing your grades for Rad Pro 2. Be on the lookout for that. And I'll send you the rest of this PowerPoint. And I also will, I got to get back to getting these videos compressed for International Day. On Monday, we'll do a review for the tests on this chapter. We'll do a quizzes review. And of course, the test, the exam will be next Wednesday. Let me know if you have any questions. Other than that, enjoy your extra 15 minutes because we finished a little bit early. And I will see you guys at 1 o'clock. Take care. See you in a little while. Bye-bye.